Hello, everybody. I'm Rabbi Jessica Graf, and I want to welcome you to our second installment of this conversation about COVID-19 and the effects on our lives and our community as we try to understand the complications of this virus. It's very important to us at Congregation Shereth Israel to be a center for conversation and discussion and camaraderie as we encounter many things in the world, and to try and do that through a Jewish lens. So we're very grateful to all of you for being here, and also to our wonderful Rebbitzin and Dr. Jonathan Graf, who's a rheumatologist at UCSF, an immunologist, and has agreed to help conduct these interviews and conversations so that we can get some local information from people that we trust. We've invited kind of, well, I was going to say homegrowns. Dr. Jeremy Faust is in fact homegrown. He grew up here at Shereth Israel. He was a super smart kid. I'm not surprised that he turned out to be a super smart adult. And he will be in conversation today with John, talking about some issues in terms of public health and the way that he's seeing things as an ER doctor. And I'll let John introduce him. I will let you know that he's on MSNBC right this very minute. He'll be joining us in a few minutes as soon as his interview there is finished. And I'm sure that will be recorded and available for those of you who want to see his interview there. He's been interviewed all over the place in the last few weeks and has a number of articles out, which we can forward if you would like to read those. So I just want to remind you that we are a community that comes together regularly throughout the week. And one announcement, which is that all of you are welcome. This is open to Shereth Israel and the community at large. Please invite friends. Friday night at 6 o'clock, we have Shabbat services, of course, that everyone is welcome to participate in. And because of a change in Zoom policy, we have a new link. So look for that on Friday. You'll be able to sign in with the new link for services Friday night and for Torah study on Shabbat morning. So without further ado, I have not seen whether Susan and Leland Faust are on this call yet. They are, great. So I want to say Mazel Tov to Susan and Leland for raising two very fabulous sons who are out there in the world, who grew up at Shereth Israel and who no doubt do everything that they do through the lens of their Jewish education from Congregation Shereth Israel. So I will turn this over now to John to begin talking about COVID. And I want to remind you all that the chat function allows you to submit questions throughout this process. We will not be able to answer all of them, but we will certainly try to address as many of them as possible. Thank you to those of you who submitted questions prior to today. And I know that John is planning to address as many of those as possible. So thank you so much for being with us.
So thanks, Rabbi Jessica. Welcome back, everyone. This is the second in our series on the pandemic of the SARS-CoV-2 coronavirus. We, as you just heard, were supposed to be joined by Jeremy Faust at this time, who is an ER physician at the Brigham and Women's Hospital in Boston, and is a noted columnist and commentator for almost every major news network in the country. And as true to form, we were notified a few hours ago that he had in fact been requested to be on an interview with Chris Hayes, I think, at 5 o'clock. So he's following a US Senator from Illinois. So assuming she doesn't talk too long, he's supposed to go on sharp, should be talking right now, and it's supposed to be done at 5:15. So hopefully he will be joining us very shortly. So I thought before he comes, and I actually formally introduce him and explain why it is that we invited him specifically to talk in our second series, I'd go back and review a little bit about what we talked about last week and address some questions that sort of lingered from last week's sessions. Rest assured, those of you who submitted questions last week that we didn't, about things that we didn't address, and those who submitted questions in the interim between last week and this week, all asked very good questions, most of which are actually right up the alley of what Dr. Faust is going to talk about today. which is why we didn't address those specifically last week. But let me take a gander at a few other questions that people asked that may not be asked of Jeremy today. So a lot of people had questions talking about the nature of the viral infection itself, and what it's like to, pardon me? To actually manage the viral infection, what some of the clinical symptoms look like. So we got a question from one congregant who talked about or asked about the blue toe syndrome. So I don't know, those of you who have read out there have been some novel clinical syndromes that have purportedly been associated with the coronavirus infection. This includes a syndrome of blue toes, or something that we call pernio, developing particularly in children and young adults who are infected with the virus. There's some of you may have read an article in the New York Times about a syndrome called Kawasaki disease, which is something I actually studied when I was a fellow, developing in kids as well who get the coronavirus, as well as some other unusual syndromes, neurologic syndromes and cardiovascular syndromes and things like that. So the question from one congregant to us last week was, is the blue toe, I'm confused about the blue toe syndrome, she said. I want to know, is this indicative of somebody who's actively infected, was infected, and does it have a bad prognostic sign? So what is the blue toe syndrome? So the blue toe syndrome is something that we call a vasculopathy. It's usually due to either a diminished blood flow in the small vessels, both in the skin, particularly in what we call acral areas of our body, but areas that are gravity dependent. In the toes, for example. Occasionally it can be in the fingers as well. And we can see this develop in a lot of people who have circulatory problems, but in particular, we can see it in people who are sick, people who have autoimmune conditions, such as the ones that I treat, like lupus, for example, or other diseases like vasculitis, where there's inflammation involved in blood vessels that causes the blood not to flow very well. And when blood doesn't flow very well, it tends to get stuck in the areas of the body where the blood vessels are the smallest. And those tend to be the areas like in our fingers and our toes, which are not only small, but also very cold areas of our body. And it's not surprising that in a lot of bad viral infections, and in particular with COVID, we're starting to see syndromes where patients are presenting almost as if they have frostbite, where they have these sort of bluish black looking toes and they develop little nodules, painful little nodules on their extremities that we would otherwise refer to as something called pernio. Does this mean they have the active viral infection? We don't know. That's why the question, and the person who wrote the question, I think, is frustrated hearing conflicting information coming back and forth. But I think what it almost certainly represents is it's an inflammatory response to the viral infection. Whether the virus is still around or not is almost irrelevant. And that what's obviously happening is that the vasculature is, our blood vessels are not just hollow tubes. They actually are comprised of living cells that line the inner lining of our blood vessels and that are very much dynamic and alive. And for example, when we go jogging and exercise outside, our blood vessels dilate because the cells that line the blood vessels are able to get signals that tell it to release substances like nitric oxide that tell the blood vessels and the muscles that line the blood vessels to relax, for example. So blood vessels are living tissue and they're very, very dynamic. And sometimes in the setting of an inflammatory disease where the immune system is activated, the surfaces of the blood cells start becoming very, very active, and blood can actually begin to clot or not flow very freely through those surfaces. And that's almost undoubtedly what's going on in cases where these kids are developing these blue toes. So they may have an ongoing viral infection. They may have the immunologic effects of the viral infection itself, but it doesn't necessarily mean that this person's going to go on to develop end organ damage or go on to develop respiratory disease or die from the disease. It's just something that's been noticed in a lot of kids, and it may be an interesting clinical symptom that allows researchers and doctors, for example, to identify cases and otherwise patients who don't have classical symptoms and test them and discover that actually kids can carry this virus as well and spread it around. So it's more of an interesting finding that's allowing us to identify the disease in a wider population of people. The last thing I'll say is that there's some evidence, there's evidence published in the New England Journal of Medicine this week of a series of patients who develop antibodies in the setting of the virus that are associated with clotting. We call these phospholipid antibodies. We often can see these antibodies in patients who have viral infections, again, in general, and they tend to be transient and they're not particularly pathologic or pathogenic. And so we don't know whether the association of these antibodies in kids with COVID, or I should say in patients with COVID, is specifically associated with clotting. But we do see clotting in people with COVID and who are otherwise sick with other kinds of systemic diseases. And we do see these antibodies in people who have COVID. So you could put 1 and 1 together, and if it adds up to 2, you can draw a conclusion that maybe patients are getting a syndrome of clotting because of these antibodies. But the 2 also may be completely unrelated. And again, we don't know the answer to that. So that's a long answer, hopefully somewhat simplified, to a question from one of our congregants about the vascular manifestations we're seeing in patients, including, I think, in this particular congregant's child. So we have a lot of questions that came in over the last week about the epidemiology of this disease. Where did it come from? Where is it going? How many cases do we really have in the US? And how do we figure that out, get a better idea of what's really going on? And ultimately, how do we figure out, more importantly, where are we going? There were a lot of questions about when can we open back up the economy and how do we do that? There was a very sweet question from one of our congregants, I think it was from you, Lisa Erdberg, but I may be wrong, so don't quote me on it, about when is it safe to go to services again, for example, and what will services look like here in the congregation in the post-COVID era once things begin to open up again. So I will answer a few of these questions. And then hopefully Dr. Faust will join us shortly and can get into a little bit more of the nitty-gritty of some of this in a second. So first of all, I think it's, I don't know how many of you know, but there's actually been a confirmed case now of COVID-19 uncovered in a French patient in the suburb of Bobigny, which is, those of you who have been to Paris, is just in the banlieue, in the outside suburban area of Paris, who presented in mid-December. With symptoms that are completely compatible with COVID, but COVID wasn't recognized then because the Chinese hadn't bothered to report the occurrence of this illness widely to the WHO at that time. And so this patient was treated as if he had had a viral infection, eventually recovered, and the French were able to go back and find his specimens. I don't know where they keep his snot specimens, where you would store such a specimen that's still viable, but they were able to go back and the specimen was actually viable. And they went back and tested it, and sure enough, the virus was there. So, so very, very interesting, and I think it points to the question of when this actually began, and the thought that this somehow began in a small little wet market in Wuhan in early to mid-December is challenged a little bit by the fact that there's somebody in France who had it within a few days after that happened. So it would have to imply this particular person's had no travel, no exposure. His wife, however, worked at a convenience store near Charles de Gaulle Airport. And frequently there are travelers who somehow would pop in. Those of you who have been to Charles de Gaulle, it's not like it's in a downtown metropolis. It's kind of out in the countryside. So this convenience mart must have been somewhere on the road where people who rented cars probably would travel through. And apparently there were travelers who would come through with suitcases and pick up goods before they went on their journey. So the thought is that maybe a traveler, perhaps from China, got off there and somehow contacted this person's wife. But other than that, there are no other leads for this particular case. So it does raise questions about whether or not this person was the first person to get the disease in France, or whether or not it was already widespread by that time, at which point he was more sort of collateral damage from community spread. And I think that's still not known. And I think it raises an awful lot of questions, certainly from China, about where the real origins and when the real origins of this virus actually began. So that answers a couple of questions about the nature of when the virus began. Let's talk a little bit about some of the ongoing epidemiology right now here in the city. So, so I can tell you that UCSF, in partnership with various social agencies in the city, did what I've been advocating to be done for a long time. When you go drilling for oil, you make your best guess as to where you want to drill, but you don't just plant your giant rig without having done a lot of research first before you build your rig, right? You do a lot of test drilling first. You dig a little bit of soil samples in the ground to get an idea of what the lay of the land actually is. And I think to begin to understand what the lay of the land is here in San Francisco in particular, one of the best things we could do is to go and do community testing, to just figure out what is the prevalence of disease in the community. And UCSF, along with its partners in the community, decided to do a community testing effort last week in the Mission. It was originally, I believe, between Harrison Streets and Van Ness, South Van Ness Street, between, don't quote me on this, somewhere maybe Cesar Chavez and like 23rd Streets, between sort of that little square grid area. And I think it was actually expanded a little bit in the end because the testing was so popular. And I believe they tested somewhere in the lines of 4,000 or so plus patients. Now, naturally, you have to be aware that there could be bias in the sampling. We're not an authoritarian state like China, although the health department does have the authority to go and, if it wanted to, knock on doors and collect samples as needed to get a true randomized sample. This was more of a community effort, a volunteer effort to get people who wanted to be tested. So there could be sampling error whereby some people who are afraid of being tested, being found to be positive, being discovered to the authorities, for example, may have hidden in the shadows. But nonetheless, it was a pretty good representative sample. Like I said, there were over, I believe, several thousand patients who were sampled. And what's interesting is the positive rate on the samples was somewhere around 2%, a little over 2%. And that's, I think, very, very interesting because if you look at the sample testing, for example, at UCSF, I just looked at the UCSF dashboard of testing. And these, of course, are people with clinical symptoms coming in who are being tested. When you look at all of the COVID testing that's been done at UCSF to date, I believe as of yesterday or the day before, about 2% of the samples have actually been positive. So it actually is very close to what was seen in a community sample in San Francisco that was done sort of in patients without symptoms, theoretically, or with or without symptoms. And it also was done, reflects what was done in the community in an area where there's been what's been thought to be a particularly high incidence of symptomatic patients, particularly those coming from the Mission. So there's been a lot of thought, and this gets, I think, a little bit at your question Bill Shore asked about why there are disparities in care, in particular with in COVID patients. And I'll start by saying that when I was the attending physician on the medicine service at Zuckerberg Hospital in March, so sort of in the early to mid phase of the COVID pandemic, it didn't, Jessica can confirm this, I would come home at night and the names of people admitted to the medicine service with a suspected or confirmed diagnosis of COVID-19 didn't escape me, that they appeared to be Hispanic names. So even before editorials were published by Alicia Fernandez and others in the San Francisco Examiner, it was very clear to me that there was a very disproportionate representation of patients, at least in the hospital, who appeared to come from lower socioeconomic areas of society, particularly Hispanic patients, probably a lot of those in the essential workforce who have to be out and working and didn't have the luxury of staying at home. And I thought that certainly was certainly profoundly struck me. But it's interesting, if you do step back a little bit, those disparities aside, and you look at the overall positive testing results from the broader community, including asymptomatic people, whether it's that semi-random sample in the Mission, if that could be considered a random sample, or whether it's the directed testing that was done at UCSF, it's interesting that the number of COVID cases appears to be consistent across the population, which is about 2%. And in fact, if you look at some of the COVID-19 statistics in California at large, and I'm going back now a couple of weeks, the demographics of COVID-19 positivity in California, and this is back before testing was expanded very, very greatly, roughly reflect the demographics of the ethnic and racial makeup of California, save for the fact that there are some more hospitalizations and more serious disease amongst African-American patients, perhaps who have other medical comorbidities that place them at increased risk. So a lot of these statistics I think are very, very interesting. And the last I'll mention sort of in response to Bill's question is, oh, Jim's on, great. So we'll get to Jeremy here in just a second. Governor Cuomo in New York announced, I believe yesterday, an interesting statistic that more than 2/3 of patients of recent coronavirus positive cases that have presented to the hospital in the last 3 days in New York City were actually from patients who were at home, who were not at essential employees, who were at work, who may or may not have gone out for social reasons or for food shopping or things like that, but who otherwise were confined to home. And this surprised him because he was assuming that a lot of the cases would be disproportionately skewed one way or the other. And so I'll just sort of say that we're learning a lot. There's clearly, I think, disparities that we're seeing, certainly in the population that I've been taking care of at San Francisco General. There's no question about it. Why that is, whether it's due to medical comorbidities, lack of access to healthcare, the fact that many of these folks are essential workers or have relatives who are essential workers. We just don't know enough, I think, about this disease at this point to render really more than an educated guess. So with that, I would like to introduce Dr. Jeremy Faust. Welcome. Are you on the line? I'm going to see if I can find you here.
Yeah,
Yes.
I'm here. This is, as you can see, I'm still.
There you are. I can't hear you very well, but
You can't. You really can't hear me at all? Or is it not good?
Is he unmuted? He's unmuted, I think.
Yeah, it's soft, but
Ooh.
we can hear you.
Hold on.
Gordon, let's see if you can rescue us here. He looks like he's unmuted at the moment.
Yes, he is
Okay.
unmuted.
Please check.
Maybe we'll push up the gain on your microphone a little
So
bit.
while
How's that?
Jeremy's can't hear you yet.
No. Can I? Let me call you back. Let me.
No,
go-
you're good.
Okay.
Are you sure?
Can't
yeah.
hear you at the moment. No, still.
But, so Jonathan, you may have turned your speakers off because you're sitting in a room with Jessica.
Let's see if
Okay.
he's able to come on.
Fine. Hi, Roberta.
No, I'm on here, I believe.
You can hear me. Wait.
Oh, now I can hear you. Yes.
Okay. Oh, thank God. Okay.
Now I'm up all the way here. Okay, good.
As you can see, this is the fake backdrop of the Chris Hayes all-in MSNB thing. So they're letting me squat in the studio here.
Well, thank them profusely for this. It's a travesty that you had to follow a politician, Jeremy. I can't imagine. They should have had you go first, let the senator from Illinois go second, actually.
Anyone other than Tammy Duckworth, I think I might have made a stink, but she's pretty much an American hero. So I was like,
Yes.
okay.
So let me introduce you formally. Jeremy Faust is an assistant professor and instructor of emergency medicine at the Brigham and Women's Hospital, which is one of Harvard's main affiliated hospitals in Boston. He originally went to Mount Sinai School of Medicine and did his residency at Mount Sinai as well, and was initially, I think you were an attending physician at Elmhurst, right? And before moving on to
Training. Part of my training was 50-50 with Elmhurst and Mount Sinai.
and Mount Sinai, and then moved on. For those who don't know Elmhurst is really in the trenches, to say the least, before moving on to Harvard as well. Jeremy is what I would describe to the public out there. How do you describe yourself, Jeremy? I would describe you as a theoretical epidemiologist. We have theoretical biologists. Jeremy's a theoretical epidemiologist. He opines, as I mentioned, for many blogs, online websites, newspapers, journals, news shows. And I think what's most impressive about you, Jeremy, is that you're a provocateur. You, I think, really take data that are out there and crunch it in a way that actually, I think, makes people think in a very, very provocative way, and sometimes think differently than the status quo. And I think there are people out there who spend their entire careers, crunching numbers and doing data analyses, and getting lost in the weeds. And then there are others, I think, like you, who sort of rise above all that, sort of look at the data and using, I think, very, very sound methods and common sense, sort of make very, very, very powerful points. And so to begin, I want to ask you one question that I think struck me from one of the articles that you had written. You wrote a beautiful article explaining why COVID-19 is not the flu. And I think, there have been a lot of comparisons drawn with the flu. The flu kills 70,000 people a year. The Spanish flu killed God knows how many more. The Asian flu in 1957 killed the equivalent of 300,000 people today. We didn't shut down the whole economy for that. This is not the flu. I've already had two of my high school teachers die from this back in Washington, D.C. I had a professor of mine at UCSF who was living in Paris also die from this. I don't, in my memory, know of any of my family, friends, colleagues, teachers, or patients that I've treated who I know of who have specifically died from influenza. Matter of fact, I've never written on a death certificate in my life in the last 10 years. But that's different for COVID, and I want you to explain that to the group here.
Yeah. Well, thank you for having me. Maybe you mentioned before, Sharet Israel is, where I grew up. So it's like, I feel like, you finally got me to come back after my bar mitzvah and confirmation. So that worked out.
I certainly did mention that.
But it's great. And you'll be happy.
Sorry. I certainly did mention that, I was going to say, and I mentioned your parents, and I said you were a really smart kid. So we're thrilled to have you back.
And so I'm late. I really feel bad. Sandy, as I said before, Sandy Koufax is rolling in his grave because I didn't say no to Chris Hayes to be on time for you guys. And Sandy Koufax missed the World Series for Yom Kippur. So I'm clearly not on his level. And I should also mention, and then I will get to the question, I promise, that 2 or 3 weeks into this whole thing where I went from being a person who writes about medicine and teaches medicine and practices medicine with a little bit of notoriety in the field of emergency medicine. And all of a sudden now I'm like on this national scale and all these things. And I got offered an interview by someone who I just really didn't agree with their politics and maybe didn't even agree with, well, not even their politics, but who they were as a person, but they had a huge platform. And I didn't know what to do. And the only thing I could do was to call Rabbi Wiener, was to call Marty Wiener, and who I hadn't spoken to in 10 years. And the last time I spoke to him was a random, so, you just have to go back to your roots at some point. And I mean, I'm sure, that Rabbi Graf will identify with this. This is why we do, well, not this is why we're Jewish, is this just to have this framework and to have this continuity. And I needed to talk to somebody who knew me since I was a kid, and also who I knew his framework. And he asked me some questions I didn't know the answer to, and I thought about them, and I came to the determination that I was going to say no to the interview. I didn't do it, and I don't think I could have gotten there. So I've been thinking about Sheretz Israel a lot lately because I think every challenge that we face, our private lives, our public lives, how you respond is basically some kind of product of who you are and where you came from. And I needed to be reminded of that a little bit. And I knew that I needed to be reminded of that, which is why I called him, but I needed to be reminded of that. And he told me what I wanted to hear. I think even though it wasn't clear at first, that's what I wanted to hear. I wanted his permission. I wanted to tell me, no, I didn't know. And so it was really good. So anyway, I just wanted to put that out there and to say it, thinking about this community a lot lately. So I'm glad to be here. Now let's talk about numbers and flu. Here's the deal. Yes, I look at data and I try to think, what's going on with that? And I don't try to be contrarian just to be difficult. I try to do it in a way that's productive. And I always have to speak to some experts who really are the data crunchers, who are the true quants, the wonks, to make sure that I'm not off in the wilderness and just a wing nut or whatever. But before COVID happened, I've been thinking about this, which is that think about the things that kill 40, 50, 60,000 people per year. Gun violence, opioids, motor vehicle accidents, and how often do I declare deaths of those people? And it's often. It's part of my job, and I've got a speech for that. I've got 10 speeches for each of them, but I have a kind of, okay, here's what happened, and I'm going to break the news, and so they also told me that the same number of people die of flu every year, and I don't have a flu speech. And I don't have a flu framework. I have a sepsis framework for pneumonia for patients who are, but I don't, influenza just wasn't there. And so I thought, this is completely crazy. Like, what is that? And I did a little work on this, and I've discovered a guy, you're never the first person to think of something. And 10 years ago, this guy who was up at Harvard, now he's elsewhere, had actually kind of written about the CDC's methodology. And basically, which is what I wrote about in this piece that I wrote for Scientific American eventually. And what it is that the CDC doesn't count the number of flu deaths. They estimate them based on assumptions and assumptions and assumptions. And those assumptions have always just felt kind of like no one paid attention. It's like, oh yeah, 60,000 people die a year of flu. So just whatever. And no one bothered to like put that to the whiff test of like, well, yeah, but what Dr. Graf is saying, like, have I ever seen that? And so I started calling my friends because like I'm an ER doctor, maybe I'm missing something. So I called the ICU friends I have, I called people in different fields, and they all say the same thing, like, holy crap, like you're right, like that's true. And so I just thought, yeah, at some point there's gonna be like a cool article to write about this. I just had this in the back of my mind, but I hadn't really done the deep dive. And then COVID started happening, and people started comparing it to the flu. And I never said anything about the flu when this thing came out. I resisted that, which I think was wise. But I didn't know what was going on because no one knew what was going on because the stock market was at an all-time high in late February. So anyone who says they knew this was coming, I want to see that they sold their stocks because I certainly didn't. I know one man who did, and he's a mathematician and he's doing well. COVID happened, and I thought, gosh, they're comparing it to flu. And now that's not good because this thing is worse than flu. It's got to be. So then the CDC statistics are out there, but they're really buried, and you have to dig and dig and dig. And I noticed on one of their websites for coronavirus, they actually published not the estimates, but the counts for this year. And I thought, boy, they've never done that before. I've never seen the actual counts. I kind of feel like they're provoking me. I almost feel like they're asking for this. Like some of the CDC is like sending out a call for help. Like, hey, by the way, we hear that people are comparing this to flu. We get that it's not. We get that our game is up. We get that the previous thing of overestimating them used to be a really good idea because it would help people get vaccinated more. It would help them wash their hands more. It would help them make their checkups more you know, all these good reasons to do what they did. And they never thought of the simple thing, which is it's never good to BS because it actually has downstream consequences that you can't possibly imagine. Who the hell could have thought that the president of the United States, or even the Surgeon General, who's a really smart guy, who's not a crazy person at all, he's a very good doctor, would get up there and say, the flu is much more important than this thing in February. No one would have ever imagined that. But it's a good lesson not to gaslight people because you never know what's going to happen. So stick with the truth. So what I started to do is to dig into the actual number, and the CDC sort of, if you dig in, you eventually find out that, yeah, they do actually bury the true actual counted number of influenza deaths every year. And it's probably, some people say, oh, well, they're undercounting. And I say, no, they're actually probably still overcounting because those death certificates that they are counting can also include pneumonia, can also include cancer. It's amazing. So the numbers that I cited where I said that I found that it turns out that coronavirus every week so far, roughly lately, is killing around 20 times the number of people that flu kills in the worst week of flu season, week to week. And it's as high as 44 times. That all made sense. But I thought, it's probably even worse than that. So I wanted people to know that we were counting coronavirus deaths, like one by one by one, and that the CDC has been estimating the flu and combining it with pneumonia. And in reality, that never really passed the whiff test. And it wasn't until this situation that it became important. So I was like, I thought, well, at some point I'm gonna write a piece called "We Need to Have a Talk About the Flu," because it's not that bad. Yes, I don't want the flu, but it's not killing people the way the opioid crisis is killing people. It's not killing people the way cancer kills people. But the COVID situation made it really, really urgent. And the response to the piece has been unbelievable. It's like every single person is like, well, geez, you're right. I've been practicing, this guy is like a woman, infectious disease doctors. I see one per year and I work in a major hospital. So most people kind of have the same like, oh yeah, you're right. And then there are a few people who go the other way. It's hilarious. They say, well, I work in a pediatric ICU and I see 10 flu deaths a year. And I say, well, wait a second. That's funny. The CDC actually does count pediatric flu deaths. They don't count adult flu deaths. They do count pediatric flu deaths. And there's like 150 or 200 per year. You're telling me in your single ICU, you see 5% of the whole country? I don't think so. So it's funny how people still they cling to this thing. They're so married to it because it's been this thing like, flu. Yeah, flu is the worst thing. And guess what? It's not. COVID is the worst thing.
I think that's a great point. I think also the CDC's methods haven't changed very much over the years, but our ability to diagnose the flu has. We have rapid molecular diagnostics now. Don't just test for the flu, but they test for flu and about 20 of the other related respiratory viruses, everything from the common cold to other coronaviruses, all from one little swab of your nose. So, our testing ability to look at these things has changed dramatically. And I now know every case of somebody who comes in with influenza, whether I think it's related to why they're in the hospital or not. And I treat dozens of people a year, but they don't die from the flu as the primary thing, the way that I've seen people die from COVID. It's very, very different.
CDC will say, oh, no, you're underdiagnosing the flu. We think you're underdiagnosing it. That's why we add these coefficients and multipliers. And I'm like, are you crazy? Anyone who comes in my ER with a sniffle gets a flu swab. Like, I mean, and that's the same thing everywhere. And I know that's true, by the way, because I know how many people are on Tamiflu, which is this medication that we give for flu that doesn't work. But that's another story.
That's a great question. So along those lines, so we really, this is why we needed to take this seriously from the very, very beginning, and why we still need to continue taking it seriously right now. David Newman, one of our comments, wrote a very, very interesting question. I'll actually read it verbatim and get your response to this, Jeremy. So he actually asked two long questions. One is about herd immunity, which I can deal with later in the session. But the first question he asked is, he said, the recent White House estimate is that the daily death toll will rise from 1,750 at the end of April to 3,000 at the end of May. Assuming that the increase is more or less a straight line, that projects to an average daily death toll of about 2,300 per day for the month of May, or about 70,000 deaths for the month of May. Since we are at roughly 60,000 deaths at the end of April, that would mean a total of about 130,000 deaths by the end of May. The recent University of Washington estimate projects 130,000 total deaths by the end of August. How do you reconcile these numbers? And I think it gets again at how, can you speak a little bit to how we model these diseases? And the fact that I think what people don't really fully grasp is that these are models, and they take a whole host of assumptions into effect about how many people are in close contact with one another, how the virus is spreading in certain communities, what the future economy is going to look like, and a whole bunch of other unknown variables. And I'd like to get you to sort of address the quote unquote certainty with which people seem to be operating on based upon these mathematical models.
Yeah. There's every single one of these models, you have my permission to completely ignore. Just take them and incinerate them. And let me tell you why. Well, I'll give you an example of why it's true that will ring true, and then I'll explain why. On April 4th, some guy said, the revised projections say that by August, we're going to have only 60,000 deaths. Some guy said that. That guy was Anthony Fauci, who is supposedly one of the smartest people in the planet. And he is, but he got fooled, as we are always fooled by models that have too many assumptions early in the model. Okay? If I am driving from here to home, my model says I'm going to get there in 20 minutes. The closer I am to home, the more accurate that model is. When I'm a minute away, it's pretty accurate. But when I just left, I don't know whether you're going to slash my tires. I don't know whether I'm going to get cut off. I don't know whether there's going to be a traffic accident. And so that 20 minutes is now an hour. Okay? Right now, when I look at the Waze, because I'm one of the only people who's out there driving, the Waze is like, yeah, it'll take you 25 minutes to get to work. And I'm like, really? Watch, I'll be there in 12. Because there's no freaking traffic. And so models are based on assumptions which are way, way too variable to be meaningful at all. And what I would say is we got screwed by the model prediction in April 4th. It made people feel like, oh, we're going to be okay. Facts on right now are facts. They're real. Models are predictions and they're guesses. And there are so many models that some guy or a woman is going to be right. And then we're going to say, oh, wow, look at that brilliant person they were the one who modeled it right. Well, there was 1,000 models and one of them is the best. It got lucky. Okay. So the problem with these models is they're useless. What we know that no one's talking about is that the number of cases that have been diagnosed so far is a tiny fraction of the number of cases there are out there. That we know. And any model that and most of them do, fail to account for that is useless. And I know they fail to account for that, and let me tell you why. Right, if you think that right now there are 400,000 active infections, that's just the number of new cases in the past 2 weeks that are documented, okay? We know that's not true. We know that it's probably 5 times that. It could be 10 times that. which ones are you picking up? Are you picking up the old folks who are really going to be in the ICU in 2 weeks? Or was there an outbreak at some hippy dippy commune in Marin with a bunch of kids whose parents let them use their trust fund money to like join this commune or whatever they're hanging out? And they're all going to get sick, but none of them are going to go to the ICU. They're all going to be fine. And so the number of people who get the infection is one thing. The number of people who die is a function of who got it. And none of the models can account for that. If we know that nursing homes have driven a lot of this conflict, a lot of this crisis, if the healthcare worker who transmitted it from nursing home A and then went to work at the other nursing home where they work, nursing home B, and we saw that case report in the New England Journal of Medicine, if they had gotten a sniffle before they had the next shift, 80 people would be alive today. I don't know a model that can account for that. And so ignore the models, demand for more testing, and keep an eye on who's getting sick, because that data is out there. We know what age groups are and who's dying.
So along those lines, I think one of the most provocative things that you've written recently, and I have to say that it got me really, really thinking about this because it makes plain sense. One of the things we do have numbers for, roughly speaking, assuming that people aren't dying at home or aren't dying elsewhere around the world, dying without being recorded by the government, and we presume everybody who dies is somehow accounted for by the government, is something called excess mortality. And you wrote, and very accurately, that the mortality rates and statistics in the U.S. generally are surprisingly consistent. Yes, there's been a gradual drop, in deaths, for example, from car accidents with seatbelts and better built cars, and cancer deaths for certain cancers have been dropping, and over many, 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 many years and decades. But from year to year, the mortality statistics in this country are remarkably consistent. And yet there are occasional blips, 9/11, for example, tiny little blips. There's a very, very clear blip with COVID-19. That's another thing that makes this stand out, I think, from the flu, that the number of people dying above the level of baseline mortality that we're seeing from other causes is way out of proportion to what you would normally see at this time of year. And you comment about how that particular statistics, being agnostic as to why people are dying. Are they dying from heart disease? They had a heart attack because they were under stress from COVID, or whether they died from COVID itself, or whether they die from whatever the reason is, from not being given appropriate medical care for their regular medical issues because the hospital was closed. Whatever the reason is, there's an excess mortality number that you can put your finger on. And you've commented about how maybe that's what can be used to inform us about when it's safer to open the economy. Since all these other models apparently are not so good, and since we're not testing widely enough to know what the true prevalence of COVID-19 is in the community.
I'm muted by the host.
Got you unmuted there.
Am I good?
Yes, you're all good.
Okay, hold on myself. Okay, great. All right, so yes, this was like a moment where I was like, just everyone talking about the number of deaths, the number of cases, and I know somewhere on my phone I've got a voice memo to myself where I'm like, excess mortality. That's the answer. And because, again, I was, when I first started looking at COVID, I was reading all the papers in China and all these papers out of Wuhan and Hubei, right? And I was like, okay, they had like 2,000 deaths. How many people die per day in that place anyhow? So I started crunching the numbers. I was like, wait a minute, I'm not sure how real this is. I wasn't sure. I really wasn't. Because their daily death rate should be like X whatever it was. And I was like, well, it's kind of like X plus 20. Like who's to know like which ones are COVID and which ones are not COVID? I just sort of mentioned this on MSNBC. I was like, I had a distant relative in her 90s who just died like 2 weeks ago, and she had coronavirus, but she'd been dying for years. Really unclear. And this is the way we phrase it: did she die of coronavirus, or did she die with coronavirus as a sort of on board, right? And that's what I wanted. I realized that most people probably don't realize that as death certificate information is really variable. It's really hard to know.
That's right.
So are you robbing Peter to pay Paul, so to speak? It's a funny thing to say in a, sharing Israel setting. But anyway, and so I was like, wait, are we having excess mortality? Are we really having more deaths than usual? And the answer was yes. We're just starting to. And that gave me a moment of severe pause and concern for the country. And I felt I needed to share that with some public officials and all that. And they looked at that and they said, yeah, that's pretty good. Not good, but it's useful to know. And what's fascinating, as you think you point out, is that when the numbers rise, you know that something is different. And also, when the numbers fall back to the baseline, you know that you're closer to kind of a normal risk. And again, look at flu for a second. Influenza does not do this. Influenza does not cause huge spikes in excess mortality, even in the worst part of flu season. It might have a little blip, and then it's funny, like a couple weeks later, it goes down. It's almost as if it killed some people who are going to die anyway. It just sort of has that pattern. Whereas this is like something we've never seen before. And I'm going to see if I can actually share my screen with you guys. Let's see here. And to show you this graph, but is it going to let me? I don't know if it'll let me. Preview, advance, maybe not. I have too many windows.
Should be the green screen share button there at the bottom of the screen.
Can I do it? Oh, it's going to ask for privacy. It might be worth it. Give me a second. If not, Jonathan, you could pull up the Washington Post because they published it. But it looks like I could do this. No, it's not going to work. That's too bad. All right. Well, anyway, the point is this. I'll draw it out. It's really easy. This is time, week 1 of the year, and this is week 52 of the year. And this is the number of deaths from any cause. And these are the last 5 years in Massachusetts. And then I asked the Department of Health in Massachusetts to give me the data for this year because they're not out yet, but they said, okay, we'll give them to you because you seem like you're doing something useful. And this is what they showed me. And this is all causes. Now, turns out that that number there, pretty much 90% of it, or less than that, but a huge portion of it matches the coronavirus counts that we're making. So it's like, okay, that seems right. And then are the other 10% undercounts? We missed them? Are they the thing that you said before, like, oh, people aren't coming in for the heart attacks and they're dying at home? I don't know. We're going to find that out. But when this goes away, when this goes back to normal, we are now at a place where I can say that if my aunt dies with coronavirus, but here's the numbers, it's not a threat to our way of life. It's not a threat to the public health in the same way. And I'm worried that if you just follow the number of cases, you're going to be really misled because in the fall, people could get reinfected. Well, if everyone who gets it in the fall already had it and no one dies, why do I care? Like, why do I want to shut down the economy for that? I don't care if there's coronavirus cases. I care if people are dying of coronavirus. Whereas if you track that and the mortality curve, then you know, oh crap, it's back and it's hitting people who actually are going to get hurt by it. And so what I'm trying to do is to get people to notice that and to use it as a major piece of the puzzle to say it's safe to reopen. And it's about a 2-week lag, by the way. We can know, we can pretty much know, well, right now it's so bad that we don't have to wait 2 weeks. We actually know the day of. We know that, like, the CDC yesterday released statistics for the country. And even though it's like, like on election night, like how many percent of the precincts are reporting, you know what I mean? Yeah, even though like very few precincts are reporting so far as of yesterday for like 10 states in the United States, already 10 of them are over the number that's supposed to be. And we know in 2 weeks from now, 30 states will join and those 10 will have higher numbers. So you can already tell that 10 states, as of right now, already still have excess deaths today. And some of them are reopening, which is just like, it's really concerning. But on the flip side, when that goes away months and months and months from now, I can imagine that people are like, oh, people are still dying of COVID. And I'd be sitting there saying, well, yeah, but we got to get on with our lives.
That's a great answer. It answered a lot of people's questions about how to get back, sort of how do they know when to go back to their normal lives. For example, trying to find one other question here. This was from a comment. I'm a youngish, generally healthy senior, but I have exercise-induced asthma and a higher than ideal blood pressure. How should I plan for the next period of time when we begin to relax shelter-in-place rules? So I think the first thing is I don't know if the common congregant or person can track excess mortality as easily as some of the health policy and statisticians actually can do that. But I think that's a good sign. And I can assure you that that good health departments, I think Grant Colfax, who's our department or DPH director here, who's himself a physician and ID epidemiologist, is tracking numbers like that very carefully, at least in the Bay Area. So, so I think you're definitely onto something. That's one of the things I think they'll actually be looking at. David Newman also wrote a second question about herd immunity, and he said that to develop herd immunity. So first of all, what is herd immunity? Herd immunity is, I'll get a little bit, is basically when there are enough people who are immune to a contagion such that the contagion doesn't have enough hosts in which to replicate in to spread the disease any further. And it's basically a mathematical calculation. And it's thought to be when you approach about 70 or so, 75% of the population is actually immune to say a virus or a similar contagion, then there aren't enough susceptible hosts to continue transmitting the disease at a rate. And that number can vary depending on how infectious an agent actually is. Like this particular coronavirus, one person can infect roughly an average of 3 people. So the number of people you would need to have herd immunity would be much higher, let's say, than if you had a contagion like the flu that is far less infectious person to person, if that makes sense. And so David Newman's question is based upon a herd immunity of 65 to 70%. In order to get to those kind of numbers in the country, you would have to have, you know, basically 240 million people or more actually have been exposed to the virus, which based upon mortality statistics would mean you'd have over 1 million deaths basically. And he wants to know, are his numbers correct and is the price worth it? And so with that, I ask you, Dr. Faust, what do you think?
Yeah. So yeah, herd immunity is very important, and we don't know what's going to happen with that. But correct, it's this idea of the number of people you infect. And one thing I'll just say is that the number of people that this virus does infect, which is called a basic reproduction number. This is like, if I get it, how many will I give it to? As you said, was initially estimated at 2.63, somewhere in that range. The CDC has revised that to over 5.
Wow.
And I will tell you that I work with a group that thinks it's far worse. And the reason that we know that is that look, the statistics of New York cannot sustain those numbers. The numbers have to be higher to sustain the rate of growth of the cases, unless this virus is only contagious for 3 days, which is not, right? The only way to make this number be 3 is if this is a very tight contagion window, which is totally not the case. And I just want to also just say that this is so complicated that I'll just say that it's not commonly understood. I mean, I will just say, I know this for a fact, Jonathan, a physician of national prominence who you have heard of emailed me today to ask me about stuff like this. And this individual kind of accidentally revealed that they have no idea what the hell they're talking about. Okay?
Wow.
And this is a very smart individual, and many of our viewers today have heard of this person probably. And I was just like, wow, we need to really make sure that we're making policy with people who actually know the definitions. And so it's really, really tricky to make policy because that's what people want to hear about. But long story short, the herd immunity question is totally scary. Because, right, let's imagine, I mean, what do you think the case fatality rate of this thing truly is? I think it's probably 0.5% is the real number.
Yeah, and you actually wrote a piece at the very beginning of the pandemic to suggest the numbers coming out of China were lower because the actual infection rate was much higher. That just wasn't being reported or tested as such. But if you figure it's 0.5% of hundreds of millions of people who could potentially get it, that's pretty staggering.
Right. So, so if you think the case fatality rate is 0.5%, so 1 out of 200 who gets it dies, and you need 280 million people to get the virus in order to have herd immunity, then yeah, it's 1.4 million deaths to reach herd immunity. What I don't know is how that works locally. So, for example, here in Massachusetts, I don't know if I said that 60% of the population, 60%, if I say this already, 60% of our deaths are from less than 1% of the population. 60% of our deaths are from nursing home patients, which is 0.8% of the population. So what that means is that, and so let's do the numbers there. I mean, there's only 38,000 nursing home patients in the state, and about 2,800 have died. That means that 10% of them have died, and that's just, and who knows what how many cases there have been, but you know, that means for the rest of the state, the case fatality rate is like even lower. It's like 0.0005, right? And so the question is which 75% can get it? If my God, if we could just give it to like the people who are young and healthy and who actually don't have a 1 in 200 of dying of this, but have a 1 in 10,000 of dying of this, then you'll still have an unacceptably high number of young deaths, which is a totally different thing that messes with our brains. We see young people dying, it doesn't make any sense. But it's just fewer deaths. So there's two ways out of this. Either all the old people die, which I'm not okay with, or all the young people get it, and even though a fewer of them die, it's at a time in their life when their kids need them or society, you know, whatever. And so it's really sad either way. I really think that the herd immunity argument that's being made in places like Sweden, where they're opening up and just saying, yeah, we're just gonna get herd immunity. I mean, that kind of line of reasoning with the numbers that David Newman gave us would make the notorious villains of history chuckle, you know, and say, thank you for doing my dirty work.
That's right.
Yeah.
You know, it's interesting. I think the British originally at the very, very beginning of the crisis were exploring ideas about whether they should, you know, shut down their entire economy or let herd immunity kind of take effect. I know Boris Johnson was experimenting with the thought based upon his health commissioners. And then when the numbers actually came out, when the models actually suggested that there would be hundreds of thousands, if not maybe even millions of deaths in the UK, and he himself came down with the virus, they very, very quickly changed their tune. So maybe in a tiny remote Scandinavian country, it can be we'll see how the experiment goes, but certainly in liberal westernized democracies where people interact freely and there's freedom of movement and association and things like that, it's not necessarily such a good idea, as you pointed out. I want to answer one more question related to this that somebody had asked, and then end with one final question for Dr. Faust before our time is up here. So there was a question about on the chat here about antibodies and immunity, and let me see if I can find it here. And it was actually about, let's see, could you please talk about antibodies and immunity? I understand we don't know if COVID-19 antibodies confer immunity, but is there a general pattern in how antibodies relate to immunity? So that's a very loaded question. I can tell you that the testing for antibodies to the virus varies widely depending upon who does your testing, who makes your test, what country it's made in, and how it's been validated. There are many ways to do the test. I can tell you that the way we do it now in our lab here at UCSF and at San Francisco General has been validated fairly stringently, actually I should say very stringently, is done to pretty high standards, and I have a fair amount of confidence in it, that a positive test means a positive test and a negative test is a negative test. But you should know that the antibody, there's still questions that we don't know. Just because you have antibodies to the parts of the virus that the test detects, so the test we use has a lot of specificity for this virus compared to other coronaviruses because it tests a portion of the virus that is specific to COVID, to SARS-CoV-2. But those antibodies to that region of the virus aren't necessarily protective. The antibodies that are felt to be neutralizing or perhaps most protective theoretically against the virus are actually to an area of the virus that's called the spike protein, where it actually binds to cells, adheres to them, and gets into cells in the body. And those aren't necessarily the antibodies you're testing for in all of the antibody testing that's done. Some may test for it, but a lot of them don't, because to make the test as precise and sensitive and specific as it can be, sometimes other regions of the virus, which are more specific to the virus, have to be antibodies against those regions are what is actually assayed for or tested for. So just because you have antibodies to the virus detected by this test doesn't mean that you're necessarily immune to it. And we also don't know necessarily what levels of antibodies you have to have in order to either be completely immune, partially immune, have a milder case of the disease. And there's even some possibilities I alluded to last week. If you look at other viral infections like dengue fever and the original SARS virus, that sometimes antibodies might not help you. They can actually enhance the infection as well. People who get dengue virus the second time get a much worse case of it. And there's been pretty convincing scientific evidence to suggest that antibodies to the virus do play a role in this. I don't want to get into the specifics of that. So Yes, it's important, I think, to do antibody testing. I think it will allow us to establish a better understanding of the prevalence of people who've been exposed to the virus, assuming that the testing is reliable, where it's done. And yes, the thought is that this virus does evoke a whole host of antibodies to different parts of the virus itself. We call that a polyclonal response to many different areas of the virus. And that some of those antibodies in that polyclonal response are neutralizing to the spike protein and are protective. And we suspect, if we look at patterns in China and elsewhere, even here, that recovered patients, most of them probably do have some degree of immunity. And therefore, the antibody testing we are doing, even though it doesn't test specifically necessarily for the protective antibodies, probably does convey some correlation with patients who should have also antibodies that are protective as well. But we don't know that for sure. And that's something that will evolve over time as we learn more about our testing characteristics and learn more about the immunology and virology of this particular virus. So with that, let me just end with one question. There was somebody in the chat line here who wrote a very, very simple point. And I'm going to relate this to a final article that you wrote that was very stimulating to me, Jeremy. And that is, why isn't it mandated that everybody wear a mask when they leave their front door, like they are in other countries? Not everybody socially distances, but if everybody wore a mask, we could prevent at least the transmission from some people to others. And I think I want to relate that question to an article that you wrote that was very interesting about why we're in a very dangerous time right now. And that was because there's this sort of symbiotic balance that you sort of described between the reality of how the virus is behaving and how prevalent it is in the community versus the people's perception of the virus right now. And it seems like we've crossed a dangerous threshold where if you look at the numbers in New York and you look at the numbers of people that are needed, that the virus per person can infect, that we are actually, in fact, still in a very, very dangerous time where the virus can still spread like crazy all over the country. And you gave some very, very convincing statistics in your article showing that if you have a meeting of 10 people, of 100 people, of 1,000 people, what are the chances that there's a COVID positive person within that close distance of the people that are there? And you sort of reflected those numbers and the reality of those with the perception out there that things are getting better, things aren't as bad as maybe they should be, maybe things are more like the flu, and it's time to open everything up. And you said that disconnect between people's perception and maybe why they don't want to wear a mask versus the reality puts us in a very dangerous time. Can you comment on that in the context of maybe we should all just wear a mask?
Well, first to masks. People going out to wearing masks, there is some even the bandanas or whatever, there's some evidence to suggest that these are helping. They help for two reasons. There's a medical reason to do it. If you sneeze or cough or breathe too hard, it kind of catches it. And we are seeing some early evidence finally that actually helps a little bit with that. It's not great, but it's better than nothing. It also keeps you from touching your face. It's a good reminder. And it's also, and there's a messaging there that we're a part of something that it's almost like a little nudge, like, oh, you're wearing a mask and don't forget to wash your hands. You're wearing a mask and don't forget to not hug the person you're saying it with. Because I think if we just go about our business as usual without the masks, I think that at first we'll be fine, and then we'll kind of get used to life again as we knew it. And I think what we're trying to say here is life as you knew it's not coming back anytime soon. So let's wear the costume. Let's it's sort of like, my mother loves this anecdote. Like the Gone with the Wind or whatever. They had all the extras. You couldn't see their belts, but all the extras had nice belts because that way they felt like they were really important, fancy people. So they would act like fancy people. Well, I kind of feel like in a way the mask does that too. It reminds you to be conscientious, and if this goes along with an adjacent point, which is which we mentioned at the end of the piece that you mentioned in Slate, which is how do you convince people to go with the program and stay sheltered in place for longer? And the answer is not to force them, not to have police power. I mean, you just can't do it. The Chinese did that, by the way, and it worked. It's why they were able to beat this thing, even though they absolutely failed to understand the rate of asymptomatic transmission. I mean, they totally didn't understand that. And you would think, given this virus, that not understanding symptom-free transmission would spell the end of the universe for a country like China, like it could here. But their get out of jail free card was they didn't know it, but they just had a draconian shutdown. So they didn't have to.
They still have to, in your your national ID card, when they scan you to get on a train or on a plane, will identify you as high risk, low risk. They can ban you from going anywhere, basically, based upon your ID card and camera surveillance and stuff. So
So they didn't answer any of that. So I don't know. I lost my train of thought for a second. We were on.
yeah. So the disconnect between.
So people don't understand why they're doing it because they don't see what's around them. And so I think it's like that D.H. Lawrence quote. The eye only knows what it sees, and the brain only knows what that is. And so if you don't see it, you don't believe it. And it turns out that with a million cases, only 1 out of 330 Americans has the virus, and most people only know about 300 people. So they might know one person. And out of New York, it's half that. So it's 1 in 600. And 1 in 5,000 Americans has died, which to Jonathan and I is a crazy high number. We're like, oh my God, an infection has killed 1 in 5,000 Americans? That's nuts. But you don't know 5,000 people. You don't need, your friend, between 2 degrees of separation doesn't get you to 5,000. About 2.5 does. And so, and if you want to believe this is real, because only by saying, oh, I know someone who died, that's the only way you will kind of acknowledge it's real. You would have to have a number like 500,000 deaths before every American on average knew one person. And we just can't afford to be there. So what the article was saying on one hand that, and on the other hand, the virus is so prevalent that when you get on a BART train with 100 people, assuming the caseloads that we have today, the odds of being on a full BART car with someone with the virus would be 20%. Obviously it's not full. That's good news. That's the good news. The bad news is we used very conservative assumptions for how many cases there are. We said what's reported. We didn't say, well, actually there's probably more. So it's a scary moment where it doesn't feel real to people, but it's everywhere. And that is a fantastic strategy for a virus to spread. And so the question I ask people is, are we truly smarter than this little program? This virus is a program, right? It's a genetic code that does stuff, and it's a program that, and we're the machine that in the old days you had discs, put the disc in the machine and we run the program, and that program is super good at spreading. And the main defense from it right now is not hydrochloroquine, it's not remdesivir, it's our brains. It's always smarter than the advantages, the freak of nature, once in 100-year combination of advantages that this virus happens to have acquired. And China said that they proved that they were by accident and by a combination of luck and skill and knowledge. For the United States, the jury is out.
So with that, thank you, Jeremy. I can't say, your capacity to understand this, to sort of raise very, very provocative, I think, thoughts and questions about general assumptions that we've been told by the media and others, by our elected officials and health officials as well. And to distill that down to a level that I think we can all understand, I think is truly, truly remarkable. Thank you so much for joining us today and giving of your time to this community. There were at one point 130 computers logged on. Most people I'm looking here are doublets, as a matter of fact. So probably 200 or more people enjoyed your very, very insightful comments today. So thank you very, very much, including your parents.
I'm sorry I was late. I feel like I'm going to never live that down, but it was a pleasure. And thank you for answering all the hard questions about immunology, because that was going to be
Thank you. You're very welcome. Yes. Yeah.
I just want to add my enormous thanks and the thanks of all of us on here, as some people are starting to write in the chat room, and we'll get lots of emails, no doubt, over the next few days with extra questions and thoughts. I want to thank these two incredibly smart and busy doctors for taking this time to be with us tonight. We are so grateful to have had access, as I said when we first started, and Jeremy, you weren't on yet, getting news and information about this very confusing, complicated topic from people that we trust so much, who are part of our community, makes all the difference, to be able to try to understand what's going on and to, as you said, frame this and put it in the context that belongs to all of us here at Share with Israel. I want you also to know that Rabbi Wiener has been on the Zoom call. So you made him proud, along with your parents and all of us who've had a chance to know you over many, many years. And I also said at the beginning, I don't think you were on here. You are a really smart kid, so I'm not surprised you turned out to be a smart adult. I'm so grateful for you taking this time. I know that it's really a sacrifice by your family and you late at night in Boston, and we're really grateful to have you. So thank you to everybody for joining us. There will be more of these conversations on COVID coming up. Please stay tuned for dates and times. You will hear about them going forward, and look forward to seeing all of you. Jeremy, you're most welcome to join us Friday at 6 o'clock for Shabbat services. Bye-bye, everybody, and thanks a million.